This video should be viewed after watching the experimental research designs video because you really have to understand the full basis of a true experiment before you can understand what a quasi-experiment is. So just to kind of refresh your memories, not trying to reteach the whole other video, but a true experimental design has three features that must be met. It must include an intervention that the researchers introduce and manipulate. It must include a control group that is randomly assigned. That random assignment is the third component. So, an intervention, a control group, and random assignment between the groups in the study. Those have to be met, otherwise, it's not a true experiment. So now this video is going to go over quasi-experimental designs. Sometimes these are called non-randomized trials, but they are still a form of experimental research in the fact that we are introducing an intervention, but they're not fully randomized. So quasi means kinda, sorta, but not fully. So that's what we're going to go over. So again, just to kind of reiterate, a quasi-experiment or a non-randomized experimental trial is a trial that does not include randomization. That's what it's often called in medical literature. It always has to have an intervention. So the researchers are creating some kind of intervention protocol that they are planning to introduce in this study. That could be some kind of diet modification where I pre-specify foods in particular portions that people have to eat. It could be a smoking cessation clinic. It could be some kind of investigational blood pressure medication. But whatever it is, the researchers are creating and introducing this intervention in the study. Okay, so it's serving as the main independent variable for the study. Okay, and then we're going to test the outcomes after our participants have received the intervention, whatever the intervention might look like. So there has to be an intervention. If there's no intervention, then it's considered a non-experimental or an observational type of design, which is in a different video that I have. So again, it does have to have an intervention. However, it's missing either the randomization or a control group, or perhaps both. So we're going to talk about that as we proceed through this video. There are two main categories that are frequently used when we're talking about quasi-experimental studies. The first is considered a non-equivalent control group design. That means we do have a comparison group. So one group is going to receive the intervention and the other group is not going to receive the intervention. The issue is they were not randomly assigned. That means I, the researcher, have somehow decided who was the intervention group and who was the control group. Okay, so because it's non randomized, it's not considered a true experiment, it's a quasi experiment. Okay, but there are two groups of people, sometimes more. There could be three groups or four groups. If we're doing different dosages of a pharmaceutical study, let's say group A gets 5 milligrams of the investigational drug, group B gets 10 milligrams of the investigational drug, and group C is the comparison group that doesn't get any. They're getting just the placebo. So there's all kinds of different options when we're looking at this. I just typically use two groups when I'm discussing this because it's usually easier for individuals to understand. And then there's also the option for within subjects design, which means I'm still introducing an intervention. I just don't have a group to study and compare against. So oftentimes it's just one particular group that is studied before and after the intervention. And I'll give some examples in a little bit to hopefully make these new concepts clearer. So one common quasi-experimental design that's used in nursing and other allied health disciplines is the use of a pre-test, post-test design that has non-equivalent control group. Okay, so if you watch the experimental design video, you were familiar with these different symbols that I used. But just to refresh your memory, O is outcomes or observations. So you can think of that O on the slide as data collection. Okay, I'm collecting some kind of data particular to the outcome of my study. So that could be a biomarker like blood pressure or head circumference in a newborn, or it could be a questionnaire, say a 10-item Likert scale kind of summed questionnaire. But both groups are going to receive the same data collection. One group receives the intervention that I've planned and one group does not. They're serving as the comparison group for this study. And then after the intervention, I check my outcomes again. So baseline or pre-test and then post-test. Okay. Now you may have noticed that I'm calling this second group a comparison group instead of a control group. And that's pretty standard in quasi-experimental studies. They're often called comparisons and not controls because they're not randomly assigned. Okay, so you can think of this as an example. Let's say that I wanted to look at Tai Chi exercises as my intervention. I wanted to do a 3 times a week structured exercise program using Tai Chi, and my outcome is on range of motion or overall physical activity minutes in older adults. And let's say my sample is all residents of a nursing facility, a nursing home. So note that there's no randomization here. So that means perhaps I have contracted with 2 different nursing homes. One of them is going to be my intervention nursing home. So that means that my interventionist, my folks who are going to deliver the Tai Chi program to them 3 times a week, is only going to have to go out of convenience to one nursing home. The other nursing home across town is not going to receive the exercise intervention. So they're serving as my comparison group. And so I'm going to collect the same baseline data on both residents of the residents of both nursing homes. And after the fact, I'll collect the same data again. And my hypothesis is that my intervention group should have better outcomes, more physical activity minutes per day as compared to my comparison group. Okay, so this is a pretty commonly used design. The weakness of this is that it is not randomly assigned. So I have taken the assignment into my own hands. I selected one nursing home to be intervention group and one nursing home to be control group. The problem with doing it that way and not randomized is that there is a good chance that the residents at both nursing homes are going to look very different. So let's say that the mean age of the residents at nursing home A are 10 years older than the residents at nursing home B. That could definitely play a role in affecting my outcomes of my study. Or perhaps there are more totally dependent bed-bound participants at one versus the other. That's also going to affect my outcome of total physical activity minutes per day. So randomization is meant or presumed to show that both groups are going to be inherently the same on the outcomes of interest. Without that, there's no way to be certain that that's the case. One advantage of this, however, is that at least we're collecting baseline data on these participants. So even though I didn't randomly assign them to one group or the other, I still know before my intervention starts those key demographic variables. So I know the proportion of independent versus dependent residents at each nursing home. I know their mean age. I know their number of comorbid conditions. So I at least have that information at the onset before I even start my intervention. So that is a strength of this design. Oftentimes these are much more convenient to do. As in my example, it's a whole lot more convenient for me to send my exercise therapist to one nursing home as opposed to 2 different nursing homes. This is a much weaker design. It's still considered a quasi-experimental study because my conditions are met. There is an intervention. So there's 2 groups. One receives the intervention and one does not. But we're missing some things here. This is called a non-equivalent control group post-test only design. So we still have intervention, we still have data collection, but it's only after the intervention is done. That's where the post-test only comes into place. And it's considered non-equivalent control group because there's no randomization. So we have the 2 nursing homes that I used in my previous example. The only difference is we don't collect baseline data. And why that is weaker is for the exact same reasons I said the last one was a stronger design. is because before we start our intervention, our Tai Chi program, I don't know what those residents look like. So I don't know if one group is older or more dependent or has more comorbid conditions like diabetes or Parkinson's or dementia. I don't know that at the onset. So we're going into this without any preconceived ideas, and we're just going to do our intervention and collect data once. So there's definitely some risk for bias. This is not a very strong study design, but it is used because it's easy. Okay. And so sometimes easiness or practicality is used as a factor for design decisions. These are another couple of types of quasi-experimental designs, and you can see within subjects. That means there's only one group of people being studied. We don't have a comparison group with this. So the only thing that makes this quasi-experimental is that we're still introducing an intervention. Okay, so this is still quasi-experimental because of the intervention. It's just missing a control group and it's missing random assignment. Okay, so the very, very weak design is considered a one group pre-test, post-test design. So as based on the symbols, we collect baseline information, we implement our intervention, and then we collect post-test or post-intervention data. This is very commonly used in like quality improvement endeavors. So if you think about a single hospital that had a tremendous number of falls, okay, especially at shift change time. The patients were falling more often. And so the staff and the educators and the leaders decided to do a bundle, a fall prevention bundle, and they implement that as their intervention. That is something that they are introducing. They've designed and implemented this intervention. Okay, so we have the pre-intervention fall data. We know what their fall rates were. We know before the intervention how many falls, when the falls were happening, what the participants look like who were falling. Like, were they older? Did they have dementia or some kind of cognitive deficits, altered mental status, those kinds of things? Were they on heavy doses of opioids? Were they on patient controlled analgesia? When's the last time we rounded on them? So we have that baseline data. Then we implement our fall prevention bundle. And then we track data again after we've had time to implement the intervention. Did our fall rates decrease on our unit or in our department? If so, yay. But time out on that, because how do we know that our intervention actually caused the outcome and that it wasn't something else? Like perhaps the patients just weren't as sick, or maybe they didn't have as many fall risk factors as those who were pre-intervention. So that could be a problem. Okay, so we need to consider that these designs, while still good designs, it's very likely that there are competing or alternate hypotheses that explain why our outcomes happen, confounding variables. Okay, so we can't necessarily say with a good certainty that our intervention caused the outcome because this is a weaker design. It will be done. You will see these studies and research reports published in journals that state that the outcome was caused by the intervention, but was it really? How strongly do we believe that based on all the other possible competing alternate hypotheses that it could explain our outcomes? This is the bottom one is a lot stronger. It's basically the same kind of design, but we collect data for a longer period of time. So it's called a time series design. And so let's use that same example. So let's say that instead of collecting fall data for 1 week, doing our intervention, and then collecting fall data for another week, let's say we do it over the course of 8 months. So we have our pre-intervention data. We can go back and look at that. That's data that we have readily available at our hospital. So we can look at March, April, May, June's fall data and track it and get a very good idea of what baseline looks like. Then June is over. July 1st, we implement our intervention and we give it a good month to take effect. Then in August, we look at August, September, October, November, and we're constantly collecting data, the same outcomes over time. And then we're going to take a step back and try to answer our research question. Did the intervention indeed cause the changes in outcomes? Okay, so now with my example that I just gave you, that could be problematic if we're using the falls example. You have to think of temporal changes in a hospital. Are patients in March, April, May, and June the same as those in August, September, October, November? We know that there are fluctuations that happen depending on what kind of unit. So if this is a traditional med-surg unit and we're getting closer to respiratory season, flu season, pneumonia, then these patients might be sicker. So perhaps they have increased shortness of breath, increased likelihood of trying to get up unassisted and falling. So we have to be very careful of that, and we have to take that into account when we're planning the studies to hopefully decrease the risk of bias as much as we can. Another thing to think about why this might be helpful is some of our outcomes of interest might be more flexible. So I'm thinking blood pressure, for example. If we only did one little intervention and checked somebody's blood pressure once and called that our outcome, what if we would have checked that blood pressure 30 minutes later? Could it not have varied quite a bit, or even 2 weeks later? So if we have something highly fluid like a blood pressure or a blood sugar, perhaps, then maybe this is a good design because we get a better idea of what it really looked like and were the changes sustained over time as opposed to just being a one and done kind of snapshot. So again, all of these are considered quasi-experimental because they still have an intervention that the researchers are implementing. They are either missing random assignment and or a comparison control group. Okay, so that means they're not true full experiments. None of these would be called a randomized controlled trial because there's no randomization, obviously. But there are strengths. Sometimes this is easier because randomization takes time and resources to be able to do. So to take that out, it would make this more convenient. However, it also makes it less amenable to true causal investigations. So can we truly say that our intervention caused the changes in outcomes? Or could it have been another competing alternate hypothesis? Perhaps. So those are things to think about when you're critically appraising studies and looking at the designs that the researchers chose.